All right, I'm going to talk about chapters 8 and 9. All right, so some terms we're going to talk about. Intrapartum period, it begins with the onset of the uterine contraction, lasts until the expulsion of the placenta, also known as labor. Many causes could be maternal or fetal. So think about maternal or fetal. So maternal, she has that release of that prostaglandin. That's why we use prostaglandin and oxytocin when we're inducing or augmenting labor, and also an increase in estrogen, and also the increase in the pressure as the baby is descending in through the pelvic cavity. In the fetal role, the aging of the placenta kind of ages out and kind of brings on labor. The prostaglandin synthesis by the fetus. The fetus also, you see a rise in the cortisol, which in turn quiets the progesterone in maternal in the mom and allows that increase of the prostaglandins. Some signs of impending labor: lightning. So here she goes from the baby being really high up and putting a lot of pressure on the diaphragm and making it hard to breathe, to the baby starting to descend into the abdominal pelvic cavity and going and dropping in down. So she starts getting engagement. So she may be able to breathe easier, but now she has more urinary frequency. You'll see an increased vaginal secretions as well as leg cramps, pressure in the pelvic region due to the baby descending, and also edema in the lower extremities. About the end of the beginning of the third trimester, she's going to start having these Braxton Hicks contractions, which basically are like very strong menstrual cramps, but they're going to start increasing and we're going to start becoming a little more regular. She'll start having cervical changes, so thinning and dilating of the cervix. She may or may not have a bloody show, which is not imminent of labor, but you'll see a breaking of the mucus plug. You'll see many women have like the ability to organize, have everything ready, go food shop and clean the whole house, make sure all the wash is folded, washed, and put away, organizing everything. And she's getting into that nesting phase. So she gets a sudden burst of energy to have everything ready for when the baby is here. Other signs very important to, I would definitely make sure you remember, is weight loss. And that is due to water loss and increased BMR. Backache as the baby's descending down, especially if the baby's more of a posterior position, puts pressure on the sciatica. And GI, nausea, vomiting, diarrhea. Your 5 Ps, we talked about those 5 Ps before. Michelle Cohen was talking about making sure you know your 5 Ps. So your powers, which is going to be, the contractions that push the baby out, the passageway, the baby is descending through the birth canal, the passengers, the fetus, the psychological response, and the position. So your powers, you have primary and secondary. Your primary is the uterine contractions, and the secondary is the use of abdominal muscles that are going to help push. Contractions have 3 phases, kind of like a roller coaster. So picture a roller coaster at Dorney Park. So it goes up, it's going up. That is your first phase, your longest phase. It's like building up. Then it kind of comes and rests at the top, which is your second phase, your acme or your peak. And then it lets go. And that is your third phase, or your decrement. Your contractions are known as how frequent they're occurring, which means what? How often, right? How often. And very, very important, make sure you understand these terms. Frequency goes from the beginning of the one contraction, that first phase, to begin the beginning of the next contraction, the first phase. So it goes from first phase to first phase. Okay. The duration, how long it's lasting. Again, so it goes from the beginning of one contraction, first phase, to the end of that same contraction or that third phase, if that makes sense. And then intensity is how strong. You can measure them with an intrauterine catheter. They could also see a rise in the top of the fundus, and it'll get really hard and you won't be able to indent. Contraction, again, the frequency is the time from the beginning of one to the beginning of the next one. Duration, the beginning of one contraction to the completion of that same contraction. In the beginning of labor, the duration is about 30 to 40 seconds. And then as labor continues, it can be, the duration could last as long as 30 to 90 seconds. The intensity refers to the strength. Like I told you, it can be estimated by palpating the contraction directly with an intrauterine catheter, like I told you, or an electronic to an electronic fetal monitor. You can palpate it. It's going to be really hard, and you're not able to indent. If it's mild, you may be able to indent. If it indents easily, it's mild, and if you cannot indent it, it's strong. And the frequency of the contractions as labor progresses is about every 2 to 3 minutes. And then up in here, that is your intensity you see here before the contraction, down here after, it's up in here. And then this tells you the frequency. Remember, the beginning of one contraction to the beginning of the next contraction. This is your frequency, and even has it right here. Frequency of contraction. So you see it goes from this point, well, actually from this point here, see where my mouse is going, to this point here. Duration is from the beginning of one contraction to the end of that same contraction. Bearing down is the ability to push. Remember, the woman cannot push until she's 10 centimeters, until she's completely dilated. Passage is has a lot to do with the size of the pelvis, type of mom's anatomy, and the ability of the cervix to dilate and efface. Station, that's always, station is kind of, you think of your ischial spines. It's an imaginary line in between the two ischial spines, and that would be at 0 station. Positive station is closer to to the baby coming out, closer to the crowning, and negative is closer to the diaphragm, if you want to look at it that way. So here you go. Here is your ischial spine at 0, and then -1, -2, -3, +1, 2, and 3. Passenger is the fetus. You're looking at interacting factors. Excuse me. The skull, attitude, fetal lie, presentation, and presenting part. Your fetal skull has 3 major parts. It has the face, the base, and the cranium. It has the ability to mold or overlap, which allows the baby to be able to come through the birth canal. The fetal head, you have your 3 parts. You have your anterior fontanelle, your posterior fontanelle, and it's diamond shaped. And again, this allows for the growth of the brain, and it allows for that molding. So here you go, your frontal, your parietal, and your occipital. Fetal attitude, I thought that was just really cute. So fetal attitude here. So the fetus's back is convex, we can see there. Chin is flexed, arms are crossed, thighs are flexed on the abdomen, and legs are flexed at the knees. So there you go, nice picture. Fetal lie is the relationship of the long or cephalocaudal or spinal column of the fetus to the long cephalocaudal axis of the mom. So there's a longitudinal, transverse, and oblique. Presentation, is it head first, cephalic? Is it breech, shoulder? Normal position of the baby. You see here, nice head first. There you go. There's another way to look at it. A little footling. Fetal position refers to the relationship of the landmark of the presenting part to the anterior, posterior, or side of the maternal pelvis. And then how do we know, is it true versus false labor? Well, true labor basically is going to have, it's going to produce dilation and effacement. Basically, the cervix is going to thin and dilate. It's going to have regular contractions, and they're going to increase in frequency, duration, and intensity. False labor does not produce any progressive dilation and effacement and very irregular contractions. And there's just a helpful chart for you. Assessment of membranes. Your spontaneous rupture of membranes may occur before the onset of labor. It's not uncommon for them to actually have to go in and break that bag of waters close to the baby starting the crown. So just because her membranes rupture does not mean that she's going to have a baby. However, we have to make sure that she has a baby within 24 hours to reduce the risk of infection with her and baby. The most accurate way to assess if the membranes have ruptured is using a diagnostic tool called AmniSure. It's 99% accurate, and it detects the PAMG biomarker in vaginal secretions present when the rupture of membranes has occurred. Nursing action is extremely important. You have 2 patients. So when those membranes rupture, what is our biggest concern? Right? A nuchal cord or a prolapse cord. So we want to assess the fetal heart rate because of the increased risk of prolapse cord. Assess the amniotic fluid for color, amount, odor. Is there any presence of meconium? When should mom go to the hospital? First time mom should wait until contractions are about 5 minutes apart, last for about 60 seconds, and are regular at least an hour. However, they should go immediately if the rupture of membranes broke, if she has an intense pain or the bloody show increases. And then positional, your cardinal movements. Remember, I showed you a video. Make sure you know these so you have your engagement. The baby is engaging. The greatest diameter of the fetal head is passed through the pelvic inlet. Then you have descent, where the movement of the fetus is through the birth canal, first and second stage. Flexion, the baby's fetal chin flexes downward onto the chest. The baby internally rotates, extends, whereas occiput, brow, and face emerge from the vagina, externally rotate, or the shoulders of the infant pass through, and then restitution, where the shoulder and body quickly follow. And there's a couple of little videos I would definitely go back and watch. All right, GBS positive can cause perinatal morbidity. It causes infections in the baby. They test about 34 to 37 weeks gestation and is treated with penicillin, clindamycin, or vancomycin will be your drug of choice if they have an allergy to penicillin. And ACOG has really good guidelines for that. They have a whole entire algorithm. Sterile vaginal exam, cervical dilation. They'll do it to check dilation, effacement, to see how far along she is, the position of the cervix, station, presentation, and fetal position. I'm not going to play the Leopold's maneuvers video or the stages of labor, excellent, excellent, excellent. Highly recommend you watch this a couple of times, do the quizzes, make sure you have a really good understanding of the stages of labor. So you have four stages. Your first stage is your longest and has your latent, active, and transitioning. Your second stage starts from the complete dilation of the cervix to the delivery of the infant. Third stage starts from the birth of the infant to the complete delivery of the placenta. And fourth is 1 to 4 hours postpartum. So in your first stage, also known as your latent, she's going to go from 0 to 10 centimeters. In a nullipara, it could last about 12 hours. And you're going to start seeing an increase in frequency, duration, intensity of the contractions. They're very smiley, talkative in the first stage, especially the latent. They're taking pictures. They're like, look at me, I'm going to have a baby. And their bag of waters usually ruptures this time. Remember, I said it doesn't always necessarily mean that it will. Sometimes they're not, and we have to go in and break them in the transition phase. Again, what are you going to be doing? Checking mom's vitals, checking the baby, checking uterine contractions, pain, checking for cervical changes, and baby's position. The next one is your active. So her anxiety is going to start increasing. She's going to go from 4 to 7 centimeters dilated. And it's going to last about 3 to 6 hours. And her descent is progressive. And these contractions are going to start getting more intense about every 3 to 5 minutes, lasting about 30 to 45 seconds. In the transition phase, the last part of the first stage, very restless, inner directed, very fearful of being alone. Don't leave them alone. We've heard some horror stories where, they don't realize how quickly that they are progressing, and then everyone steps away, and next thing you know, the baby's coming out and mom's by herself. Cervical dilation will slow as it progresses from 8 to 10, and the phase should be no longer to 3 hours. Epidural may increase the duration of the first stage by about 1 hour. And again, remember I said they may have to go in there and break those bag of waters. So they may have to perform an amniotomy if it's not been previously done. The transition phase, the contractions are really coming on fast and strong. Make sure you're really telling mom to rest in between. And she become very irritable, apprehensive, really inwardly drawn, trying to focus, asking for medications, yelling, crying, I can't take it anymore. Second stage, complete dilation, 10 centimeters, and ends with the birth of the baby, typically about 2 hours. And crowning will occur when the fetal head is encircled by the external opening of the vagina. And you'll start seeing more of these positional changes of the fetus. Third stage, really important. Some key things is, what do you see in this third stage? So you're going to start seeing a globular shaped uterus. Globular shaped uterus, extremely important. You're going to see a rise in the fundus in the abdomen, a sudden gush or trickle of blood, further protrusion of the umbilical cord out of the vagina. Again, this is the birth of the infant to the delivery of the placenta. It lasts anywhere from 5 to 30 minutes. And the placenta is expelled with the fetal side, also known as shiny Schultz, or it can be expelled with the maternal side, known as the dirty Duncan. Fourth stage is the 1 to 4 hours postpartum. You see her, those physiological changes that had occurred during pregnancy are now going back to the pre-pregnancy state. You'll see a lot of hemodynamic changes occurring. She may have hypotension, orthostatic hypotension, estimated blood loss anywhere from 250 to 500. You'll see tachycardia. Her uterus should remain contracted midline of the abdomen. Medications, uterotonics. Uterotonics are used for the prevention of postpartum hemorrhage. The most common one is oxytocin, also known as Pitocin. You don't need to know the dosages, but understand what it does. What is the action? So it stimulates uterine smooth muscle, producing contractions. And it also has an anti-diuretic property. And it's used for both the control of postpartum bleeding and also to help with placental expulsion. The second one I want you to know is Methergine. Again, don't you need to know the exact dosages for me for now, but understand that it's stimulating the smooth and vascular muscle, causing sustained uterine contractions. It is used for a multitude of issues: postpartum hemorrhage, uterine atony, which basically means a very boggy uterus, to help with subinvolution, where the uterus is going back to its pre-pregnancy state. And highly, highly important, star it, highlight it, go back and revisit it. It's contraindicated in hypertensive patients. So if they have cardiovascular disease, if they are on a blood pressure medication like an atenolol or any of your blood pressure medications, it's contraindicated. So make sure you know your patient's past medical history. The next one is Hermabate. And Hermabate is given IM, injected into the large muscle. It is also used to contract the uterine muscle, and it helps with uterine atony. Oh, an important thing is it's a prostaglandin. Oops, sorry about that. Carboprost is a prostaglandin, so it has it right here. If you look, it's not what I want to do here. If you look, prosta right here, PROST, prostaglandins, that should help you. Cytotec is the next one, also known as misoprostol. It's also a prostaglandin, prosta, and it's actually off-label use as a prostaglandin. It's actually anti-ulcer medication, and it causes uterine contractions and controls hemorrhage. Lacerations. Lacerations are tears as the baby is coming out, and we can have lacerations or episiotomies. So here are some examples of first, second, and third degree tearing. Episiotomy, the one I want you to be aware of, the most common, is your mediolateral. You see over here, your mediolateral, it's kind of in a diagonal. The midline has a tendency to tear the rectum, whereas the mediolateral is off to the side. So it's a surgical incision into the perineal body. The midline extends, like I said, right through the anal sphincter and rectum. So that is least common to use versus the mediolateral, which is safer. You want to think of your RITA, so your assessment of your incision. So you want to check for redness, edema, ecchymosis, any drainage, approximation. So, red, warm to the touch, painful, any drainage, any foul odor. You want to make sure that they clean really well. Use a peri bottle. Make sure that they're cleaning from front to back. Help out with stool softeners, because it's going to be very painful to move their bowels. Ice for the first 24 hours. Hint, hint, hint. Ice first. Think of your first aid, basic, fundamental first aid. Ice first, then heat. There is your RITA. APGAR, your newborn APGAR score. To evaluate physical condition of the newborn at birth, and they're rated at 1 and 5 minutes, and based on a 0 to 10 scale. Make sure you have it memorized. I will not be giving this to you. It'll be assumed that you know what's on your APGAR score. So it goes from 0 to 2, and you were looking at heart rate, respiratory rate, muscle tone, reflex irritability, and color. The nurse is completing a 1-minute APGAR. I think we went over these. You have the answers, so I'm going to just kind of go through these rather quickly. Overview of the neonate resuscitation. So just basically what I want you to know about this is based on their APGAR, if they have a really poor APGAR 3 or below, we're going to be resuscitating. 7 and above, don't need to resuscitate. And that's common sense, airway, breathing, circulation. Medications, pharmacological and non-pharmacological or complementary, all kinds of stuff. And she may have this in her birth plan, and it may change like the wind. Massage may work in 1 minute, and she's screaming at you, "Don't touch me," in the next minute. There's some videos there I was going to have you watch. Basically, don't get yourself hung up on all the different types of anesthesia. Just really kind of understand that some of my biggest concerns is the effects of the anesthesia. So it's going to cause maternal hypotension. These medications can pass through to the placental barrier, so the baby can have respiratory distress. It's going to make her very drowsy. Postpartumly, we're going to be assessing neurologically, make sure she's having a return of sensation in her lower extremities. It's going to make it harder to feel the urge to push or to push. It's going to it can cause ineffective pushing. It can slow down labor. Kind of go through those because we talked about those. All right, the next one is fetal heart rate assessment. Please use my notes and not the textbook for this one. Everything else, I always want you to go back to the textbook and read about. But this one, I'm going to what I want you to know is here. And I would just basically want you to know early decelerations, late decelerations, and variable. That just tells you about the electronic fetal monitoring. I would revisit VealChop. They do an excellent job of how to analyze the fetal heart rate tracings. Also, Register Nurse RN does a really good one. I'm not sure if I have it on here or not, but I would definitely go back. Make sure you know your normal baseline. So your fetal heart rate should be between 110 and 160. Tachycardia is over 160. Bradycardia is 110 or below for at least a 10-minute period. Accelerations are periodic, generally associated with stimulation, and no intervention is required. Decels, we talked about early, late, and variable. I'm going to go. So just remember, when you're looking at the top line is the baby, the fetal heart rate, and the bottom line is mom. So early, the term again is deceiving. So basically the early is the contractions are occurring. I'm sorry, the decelerations are occurring simultaneously with the contractions. And basically it's being caused, whoops, let me go back here. It's being caused by, if you want to, make sure you know this, compression of the fetal head from the uterine contractions. No intervention needed. So what is it? What's causing it, and what do you need to do with it? And there, as you can see, if we map them out, here's the decel right here, and we can map that right on down here with the contraction. Decel, map it down, contraction. Late, it means they are occurring after the contraction, causes ureteroplacental insufficiency. The baby's not getting enough oxygen for many reasons. It could be obstetrical emergency, like a placenta previa, abruptio placenta. It could be hyperstimulation with oxytocin. Remember, we use that for both induction and augmentation. Or it can be late or post-term pregnancy. Diabetes, gestational diabetes can also cause problems. So in the late, here's your contraction. And remember, in early, it should be right here, but now here is where the decel is starting. So you see the decels are happening after the contractions. What are you going to be doing? Making sure that you can change mom's position. First thing you do is get her on her left side. If that doesn't perfuse it, then you want to do a multitude of things. If you are by yourself, get help first. You can do everything under the sun, but if you're not getting help, if she needs an emergency C-section and you're getting nobody in there, you're not gonna be able, we're gonna have a really poor outcome. So if you're by yourself, get help first. If there's other people in there, then you can kind of delegate, get oxygen on, because that's going to be oxygenating both her and the baby. If there's any Pitocin running, stop it. Increase fluids, stop any Pitocin that's running. Elevate her legs, get help, and get prepared for an emergency C-section. Variable kind of look like a lot of artifact. They're kind of like jagged line looking. They're very transitory, abrupt, slowing. They'll drop down below the 110. They are variable in intensity, duration, and timing in relation to the contractions. And a variable most commonly is caused by umbilical cord compression, or a short or prolapse cord, or a nuchal cord where the cord is around the baby's neck. And so you see the jagged lines are kind of the telltale sign there. What are you going to be doing? Again, repositioning. If you can, try to use gravity as your friend and get her in the knee chest position, as you can see down here. They may assist with an amnio infusion. Again, there's nobody around. What are you going to do first? Get help. And then reposition, administer oxygen, again, 8 to 10 liters by non-rebreather. Discontinue any oxytocin and be prepared for an emergency C-section. And this slide just kind of gives you another view of those 3 types of decelerations. Registered Nurse RN has an excellent video on fetal decels. I would definitely watch that to help you. And then the next thing we're going to talk about is RH allo immunization, because I know that students struggle with the RH factor, so I want to revisit this. So if mom is RH positive, we're not worrying about it. Okay, so just right there, mom's RH positive, not worrying about it. If mom is RH negative, then we need to make sure mom gets RhoGAM. She's going to get RhoGAM anytime there's the ability of her blood and the fetal blood mixing. So if she had an amniocentesis, an ectopic pregnancy, a miscarriage, an abortion, a severe accident where she fell and got hurt really bad, and then she's going to get RhoGAM. So here it is. It occurs when an Rh negative mom carries an Rh positive baby to term. It could be miscarriage or induced abortion. She's going to receive, anytime she receives Rh positive blood, which hopefully won't be often or at all, experiences an Rh positive tubal pregnancy, and they are going to give it prophylactically. Okay. So if they don't know, they're going to be giving it. It's not going to hurt. She had an amniocentesis or a traumatic event that allowed the Rh positive fetal cells to enter the circulation of the Rh negative mom. Fetal neonatal risks could be hyperbilirubinemia, congestive heart failure, fetal anemia, neurologic, and death. So they're going to screen her at first pregnancy or that first visit. Remember, they're going to give her all those labs. They're going to screen her. If the woman is Rh negative, they're going to test the father. If the father is Rh positive, all of his offspring are Rh positive. If dad is Rh negative, all of his offspring are negative. So she's also going to get RhoGAM, also known as immune globulin, prophylactically at 28 weeks gestation. Hint, hint, make sure you know that. And she's also going to be given a dose of RhoGAM if the baby is Rh positive about 72 hours after she gives birth. And I think we went through the questions, so I'm just going to go through here. And that is the end of my recorded lecture.